It's time for another warm-up review. Let's get going. What effect might each of the following teratogens have on a developing fetus? So we got a long list here. First one is ACE inhibitors that can cause renal failure, oligohydramnios. What about the aminoglycosides? That can cause ototoxicity. Diethylstilbestrol. That's going to cause clear cell adenocarcinoma of the vagina. So that's something that you're going to see much later on when the baby is in, or that person is going to be in their teens or 20s, but it can be seen as early as 7 or 8. What about the folate antagonists? So this would be neural tube defects. We know that decreased folic acid can cause neural tube defects, which is why we give pregnant women folic acid supplements. So it would make sense that folate antagonists to cause that neural tube defect. Next, we have lithium that can cause Epstein's anomaly, which is displacement of the septal and posterior tricuspid valve leaflets towards the apex, leading to atrialization of the right ventricle. Next, we have tetracyclines that can cause teeth discoloration. And then we have valproic acid, and that causes neural tube defects. All right, that's it for the warm-up. Let's get to that lecture now.
We're finally ready to tackle the very high-yield subject of brainstem lesions, specifically brainstem strokes. So you need to be able to determine where a particular lesion is located based on the description of the neurological deficits that the lesion produces. So first of all, what's going to make you think about a brainstem lesion in the first place? Well, the hallmark findings of a brainstem lesion, in general, are called alternating syndromes, which means you have discrete symptoms on both sides of the body. So you see long tract symptoms on one side, such as hemiparesis from a corticospinal tract lesion, or a lesion to the posterior columns in the medial lemniscus. So this could be a motor problem or a sensory problem. And then with those long tract symptoms, you're also going to have cranial nerve symptoms on the other side because you're interrupting the cranial nerve nuclei. So when you see that combination of long tract symptoms on one side and cranial nerve symptoms on the other side, think about a brainstem lesion. And I want to share a shortcut method to localize these brainstem lesions so you don't have to memorize a bunch of different syndromes. The method is called the rule of fours. Now, the rule of fours has been around for at least 25 years, and it was actually published in the journal Internal Medicine in 2005. I've included a link to the article, but we're going to go through the Cliff Notes version in the study guide in just a moment. Now, the rule of fours is based on the fact that the medial brainstem and the lateral brainstem generally receive blood from separate arteries. So in the pons, the medial structures receive blood supply from the paramedian branches of the basilar artery, and the lateral structures receive blood from the AICA, which we called a long circumferential artery. And in the medulla, the medial structures are supplied by the anterior spinal artery, and the lateral structures are supplied by the pica. And we've seen that the cranial nerve nuclei are organized sequentially in the brainstem, from cranial nerve 3 and 4 in the midbrain down to cranial nerves 9, 10, and 12 in the medulla. So if we can figure out how high in the brainstem the lesion is based on the cranial nerve nuclei, and we can tell whether it's medial or lateral based on which tracts are involved, then we can identify whether the stroke is a right medial pons stroke or a left lateral medulla stroke or whatever. And from that, we can identify which vessel was occluded. There are 4 rules in the rule of 4, and each rule has 4 parts. The first rule is there are 4 medial or midline structures, and they all begin with M. So we're going to look at those in a moment. The second rule is that there are 4 side structures or lateral structures, and the side structures begin with an S. The third rule is that 4 cranial nerves originate in the pons, and 4 originate below the pons, and 4 originate above the pons. We saw this rule a few videos ago. So cranial nerves 3 and 4 originate in the midbrain. Remember, cranial nerves 1 and 2 originate in the forebrain, not in the midbrain. So brainstem strokes won't affect cranial nerves 1 and 2. Then the next bullet says cranial nerves 5, 6, 7, 8 originate in the pons, and cranial nerves 9, 10, and 12 originate in the medulla. And remember, cranial nerve 11 originates in the spinal cord because it's the spinal accessory nerve. So this means that with a brainstem stroke, the cranial nerves affected are going to tell you how far up or down the brainstem that stroke is located. If the stroke affects cranial nerves 5, 7, and 8, you know that's a stroke in the pons. If it affects cranial nerve 9 and 10, you know that's a stroke in the medulla. And then the fourth rule is that the 4 motor cranial nerve nuclei in the midline are the ones that divide equally into 12, except for cranial nerves 1 and 2, because those nuclei aren't located in the brainstem. Remember, they're located in the forebrain. So the 4 cranial nerves that divide into 12 are cranial nerve 3, cranial nerve 4, cranial nerve 6, and cranial nerve 12. And again, those are all motor nuclei, and they're all medial or midline brainstem structures. So now you can see how the rule of 4 is useful. If on your exam they give you a patient with long tract symptoms on one side and cranial nerve symptoms on the other side, you know it's a brainstem stroke. And say the cranial nerve symptom is impaired abduction of the left eye. Well, eye abduction is the abducens nerve, cranial nerve 6. So that means the stroke is in what level of the brainstem? 5, 6, 7, 8 is the pons. So this is a pontine stroke. And then is the cranial nerve 6 nucleus a medial structure or a lateral structure? Well, 6 divides into 12, so that tells us that the cranial nerve 6 nucleus is a medial pons structure. And since the deficit was impaired abduction of the left eye, that means that this is a stroke of the left medial pons from occlusion of one of those penetrating median or paramedian branches. That's how the rule of 4s is used. And based on that, you can even predict what long tract symptoms you would expect to see on the right side of the body. So let's look back at the first 2 rules in more detail. The first 2 rules help you to remember the long tract symptoms. The first rule says that there are 4 medial structures that begin with an M. There's the motor pathway, which is the corticospinal tract. So if you go back and look at the diagrams of the brainstem, the corticospinal tract is located in the medial pons and in the pyramids of the medulla. And what kind of neurological deficit would you expect from a lesion of the corticospinal tract? Weakness of the contralateral arm and leg. The next medial M structure is the medial lemniscus, which you remember is the continuation of the dorsal columns in the brainstem. So this carries vibration sense and proprioception and fine touch. And a lesion here would cause loss of vibration, proprioception, and fine touch in the contralateral arm and leg. The third M is the MLF, the medial longitudinal fasciculus, which is involved in controlling the eyes. So the deficit associated with an MLF lesion is called internuclear ophthalmoplegia. And I'm going to explain what that is a little later on. So you'd see ipsilateral internuclear ophthalmoplegia. And then the last medial structures are the motor cranial nerve nuclei. So this is where the 4th rule comes in. So which motor cranial nerve nuclei are located medially? Again, it's the ones that divide into 12. Cranial nerves 3, 4, 6, and 12. So a lesion here could potentially cause ipsilateral defects of cranial nerves 3, 4, 6, and 12, depending on what level of the brainstem is affected. So those are the medial structures. And then the second rule is the lateral structures, which start with S because they're located on the side. So the first one is the spinocerebellar tract. Now, we didn't talk specifically about that tract, but where does it come from and where's it going? Well, it's spinocerebellar, so it carries information from the spinal cord to the cerebellum. And if you look back at the drawing of the medulla, you'll see the inferior cerebellar peduncle, which is where the spinocerebellar tract runs. And a lesion here will cause ipsilateral arm and leg ataxia. The next S structure is the spinothalamic tract, which carries pain and temperature sensation. So the deficit would be an alteration of pain and temperature sensation in the contralateral arm and leg, and rarely on the trunk. Then you have the sensory nucleus of cranial nerve 5, which would cause ipsilateral alteration of pain and temperature sensation on the face. And the last S is the sympathetic pathway, and the deficit is ipsilateral Horner syndrome, which is that triad of ptosis, meiosis, and anhidrosis. So that's the rule of 4s. Now, it probably seems complicated, but as we work through these various brainstem stroke syndromes, you're going to see how these rules simplify things and help you put it all together. Let's review some specific brainstem stroke syndromes. Now, most books and lecturers cheat just a little bit. They tell you up front what the lesion is, and then they give you a huge list of deficits that lesion might cause. But on step 1, and in real life, patients don't come in with the location of the lesion stamped on their foreheads. They come in with symptoms and physical exam findings, and it's up to you to figure out where the lesion is located. So I'm going to describe some patient presentations, and then we're going to practice using the rule of 4s to figure out where the lesion is. So imagine that a patient shows up in the emergency department with acute onset of hoarse voice and difficulty swallowing, loss of pain and temperature sensation in the right arm and leg, and ataxia in the left arm. And then on physical exam, the uvula deviates to the right. So where's the lesion? Well, first of all, this patient has some symptoms on one side and other symptoms on the other side, and a combination of both long tract symptoms and cranial nerve symptoms. That's that alternating syndrome I mentioned earlier. So that suggests this is a brainstem stroke. So now we can use the rule of 4s to figure out where in the brainstem the stroke is located. Now, I like to start with the cranial nerves to decide what level of the brainstem is affected. So what cranial nerve lesions will cause hoarseness and dysphagia? Well, the vagus nerve, cranial nerve 10, innervates the larynx and also most of the pharyngeal muscles, along with the glossopharyngeal nerve. That also goes along with the deviated uvula from a vagus nerve lesion. So at what level of the brainstem do cranial nerves 9 and 10 originate? Well, if the pons is 5, 6, 7, 8, then cranial nerves 9 and 10 must originate below that down in the medulla. So now we know that this is a stroke in the medulla. Then, once we've localized the lesion vertically, we also need to localize the lesion horizontally. That is this a medial medulla stroke or a lateral medulla stroke? That's where our long tracts come in. Loss of pain and temperature sensation in the arm and leg. That's the spinothalamic tract, right? And ataxia in the other arm is the spinocerebellar tract. Well, these are both S structures, or side structures, lateral structures. So that means that this is a stroke in the lateral medulla. And more specifically, this must be in the left lateral medulla. Now, a lesion in the lateral medulla produces a constellation of findings called Wallenberg syndrome, which is about a 4 or 5 star topic for step 1. If you don't know anything else from this video, know Wallenberg syndrome. We have the symptoms associated with lateral medullary syndrome, or Wallenberg syndrome, listed in the study guide. There's loss of pain and temperature on the contralateral side of the body from the spinothalamic tract. There's loss of pain and temperature sensation on the ipsilateral side of the face from the spinal trigeminal nucleus. Remember, we said that the cranial nerve 5 nucleus is so big that it starts up in the pons, but then it stretches all the way down into the medulla. You can see hoarseness, difficulty swallowing, and loss of gag reflex because of a nucleus ambiguous lesion. Remember, nucleus ambiguous is speech and swallowing. You can have ipsilateral Horner syndrome because this affects a descending sympathetic tract. Then I want you to either circle or star the next one. Vertigo, nystagmus, and nausea and vomiting because of damage to the vestibular nucleus. Lateral medullary infarcts almost always cause some vestibular cerebellar symptoms, very common. And that includes the ipsilateral cerebellar deficits because of damage to the inferior cerebellar peduncle. We called that the spinocerebellar tract back in the rule of 4, but it's the same thing. So Wallenberg syndrome causes a very particular constellation of symptoms. No motor weakness, and no sensory deficits other than pain and temperature. But you can have any combination of these other symptoms. Again, it's very high yield for step 1. Then the next question says, which vessel is most likely occluded in a patient with a stroke of the lateral medulla? Well, the lateral medulla is supplied by the pica, the posterior inferior cerebellar artery. You might also hear this called pica syndrome. And if you look at all the structures there, you can see how it causes all these deficits. Let's consider another patient. Say they give you a patient who comes in complaining of weakness in the right arm and leg and numbness in the right arm and leg. And on physical exam, he has decreased vibration sense and proprioception in the right arm and leg. Plus his tongue deviates to the left. So again, start with a cranial nerve defect. Which cranial nerve provides motor innervation to the tongue? It's the hypoglossal nerve, cranial nerve 12. So what level of the brainstem is this? Well, cranial nerve 12 originates in the medulla, right? And then the arm and leg weakness comes from corticospinal tract involvement. And the sensory deficits in this case are due to the involvement of the medial lemniscus, which was the continuation of the dorsal columns in the brainstem. So the motor tract and the medial lemniscus are both medial or midline structures, so this must be a stroke of the medial medulla. And it has to be the left medial medulla because it's causing weakness and numbness on the contralateral arm and leg, or on the right side. Plus, we said that with hypoglossal nerve lesions, the tongue licks the lesion. So the tongue deviating to the left goes along with a left medial medulla stroke as well. And maybe you remember rule number 4, which said that the motor cranial nerve nuclei that are medial are the ones that divide into 12. So the cranial nerve 12 nucleus is a medial structure as well. So it all fits. So to reiterate the findings of medial medullary syndrome, there's contralateral hemiparesis, or arm and leg weakness, because of damage to the corticospinal tract. And this is an upper motor neuron lesion, so this is going to cause spastic hemiparesis. There's damage to the medial lemniscus, which causes contralateral sensory deficits, tactile and kinesthetic defects. That's another word for proprioception. And then the hypoglossal nerve damage will cause the tongue to deviate toward the lesion. The patient may present with slurred speech because the tongue isn't working correctly. And remember that the vessel involved is the anterior spinal artery, which supplies blood to the medial structures in the medulla. So hopefully you're starting to become more comfortable with the rule of 4s, because we're going to go through the rest of these a little bit faster. Say you have a patient with left facial droop affecting both the upper and lower face, loss of pain and temperature sensation on the left side of the face, and loss of pain and temperature sensation in the right arm and leg. Now in this one, the facial droop suggests cranial nerve 7, which originates in the pons. And the sensory deficit suggests that enormous spinal trigeminal nucleus and the spinothalamic tract, which are both S structures or lateral structures. So this is a stroke of the lateral pons. And specifically, this is the left lateral inferior pons because the facial nerve nucleus is located in the inferior pons. So the symptoms of lateral inferior pontine syndrome include ipsilateral facial nerve paralysis because this affects the facial nerve nucleus. If this were the superior pons, you might see trigeminal nerve involvement and jaw weakness. You'll see ipsilateral limb and gait ataxia, ipsilateral loss of pain and temperature sensation on the face. You're going to see contralateral loss of pain and temperature sensation on the body. So the ipsilateral loss was in the face, contralateral loss of pain and temperature sensation is in the body. And you might have ipsilateral Horner syndrome because of the sympathetic fibers. Lateral inferior pontine strokes can be caused by occlusion of the anterior inferior cerebellar artery. But there's a lot of collateralization from the superior cerebellar artery and the pica, so lateral pontine strokes are fairly uncommon. Here's another patient presentation. Say you're seeing a patient with inability to abduct or adduct the right eye, horizontal nystagmus in the left eye when looking left, left arm and leg weakness, and loss of fine touch, vibration, and proprioception in the left arm and leg. Now, in this one, the cranial nerve lesions could be confusing with the nystagmus and so on, but notice that we have an inability to abduct the right eye. That suggests a right cranial nerve 6 lesion, doesn't it? And if you think back to rule number 4, cranial nerve 6 divides into 12, which reminds you that the cranial nerve 6 is one of the motor nuclei located medially. Now, the arm and leg weakness suggests corticospinal tract involvement, which is a medial structure, M for motor. And then the sensory deficit suggests the medial lemniscus. So this all suggests a stroke in the right medial pons. So with medial pontine syndrome, you have contralateral spastic hemiparesis due to corticospinal tract damage. You have contralateral loss of light touch, vibration sense, and proprioception due to medial lemniscus damage. You may see internuclear ophthalmoplegia due to damage of the MLF, the medial longitudinal fasciculus. I'll explain what that is in just a moment, but this is part of the eye findings I described and also the nystagmus. Adjacent to the MLF is a structure called the PPRF, the paramedian pontine reticular formation. So both the MLF and the PPRF are involved with coordinating conjugate gaze, and damage to the PPRF makes the patient gaze drift away from the side of the lesion. We didn't see that in our patient, but you certainly could. But we did see ipsilateral paralysis of the lateral rectus muscle due to damage of the cranial nerve 6 nucleus, the abducens nerve. Now, we said that lateral pontine strokes are uncommon, but medial pontine strokes are much more common. And they usually present with prominent ophthalmoplegia or eye movement problems. And what vessel is to blame for medial pontine strokes? The basilar artery, or more specifically, the median and paramedian branches of the basilar artery, which are the branches that penetrate the pons. So what kinds of ophthalmoplegia or eye movement problems are we talking about? Well, I mentioned it's called internuclear ophthalmoplegia, which is caused by a lesion of the medial longitudinal fasciculus. So sometimes you're going to hear this called MLF syndrome, for medial longitudinal fasciculus. Now the MLF is a structure in the pons that helps the eyes track together when you look side to side. It allows the lateral rectus muscle on one eye to coordinate its movements with the medial rectus muscle on the other eye so that your eyes can kind of look in the same direction at the same time. So if you lesion the MLF, you're going to get a medial rectus palsy when you attempt a lateral gaze, when you try to look side to side. In letter A, the patient is looking straight ahead, which looks normal. In letter B, the patient is looking to the right, which also looks normal. But in letter C, when the patient looks to the left, you have two problems. First of all, there's a medial rectus muscle palsy in the right eye because the MLF lesion is on the right. So the left eye abducts, but the right eye cannot adduct. So the right eye just stays looking straight ahead. And then the second problem is that the left eye, which is abducting, has horizontal nystagmus. So if the patient looks to the right, there's no problem. But if the patient looks to the left, you have medial rectus palsy in the right eye on attempted lateral gaze, plus nystagmus in the left eye. But if you ask the patient to cross his eyes to focus on something up close, that's called convergence. And convergence is normal. So the medial rectus can function, it just doesn't work on attempted lateral gaze. And I want you to know the two main clinical situations in which you're likely to see internuclear ophthalmoplegia. They're multiple sclerosis, especially in patients younger than 50, and in older patients, those over 50, think about medial pontine strokes. While we're talking about lesions in the pons, I also want to mention something called locked-in syndrome, which is where the patient is fully awake and alert and aware of what's going on, but he's not able to communicate or move anything except the eyes. It's like you're locked into your body. Now, locked-in syndrome occurs due to basilar artery strokes that affect both sides of the superior pons. It's also classically associated with rapid correction of hyponatremia, or low sodium, and this can lead to lysis of the myelin in the central part of the pons. We call this central pontine myelinolysis. And on MRI, you're going to see this as an increased signal intensity in the pons. It's pretty rare, but that's a classic association. And then the very last topic I want to cover is a midbrain stroke, which is called Weber syndrome or Weber syndrome. But Weber syndrome is another 3 or 4 star topic. Weber syndrome is caused by an anterior midbrain infarction resulting from occlusion of the paramedian branches of the posterior cerebral artery. This causes infarction of the cerebral peduncle, which were those wings on the anterior surface of the midbrain cross sections, just anterior to the substantia nigra. And within those cerebral peduncles, you're going to find the corticospinal tract and the corticobulbar tract, which carries motor signals to the medulla. That's what bulbar means, medulla. Now, infarction of the corticobulbar tract will cause problems with swallowing and speaking and controlling the tongue. An infarction of the corticospinal tract will cause contralateral hemiparesis and weakness in the arm and leg. And because the fibers of the oculomotor nerve run right past here, you can also see ipsilateral oculomotor nerve palsy with ptosis, pupillary dilation, and lateral strabismus, which means the eye is going to look down and out. Now, for the end of session quiz, we have some more patient presentations so you can get more practice using the rule of 4s. So try those on your own, then we'll go over the answers. First question. A patient comes to the ER with double vision and left-sided weakness. On physical exam, she cannot abduct her right eye. In addition to motor weakness of the left arm and leg, she also has loss of fine touch, proprioception, and vibration sense in the left arm and leg. Where is the lesion and what vessel is most likely involved? Well, this patient has a right cranial nerve 6 palsy and involvement of the right corticospinal tract and the right medial lemniscus, so this is a lesion of the right medial pons. And the vessels that supply this area are the median and paramedian branches of the basilar artery. Next, a patient presents with vertigo, nystagmus, and slurred speech. Physical exam reveals right-sided ptosis and meiosis, decreased gag reflex on the right, deviation of the uvula to the left, diminished pain and temperature sensation on the right side of the face, and diminished pain and temperature sensation on the left side of the body. So where's the lesion and what vessel is most likely involved? Well, this patient has Wallenberg syndrome, which is a lateral medullary stroke. In this case, the lesion is in the right lateral medulla, and the vessel is the right pica, the posterior inferior cerebellar artery. And the last question. A patient presents with double vision, slurred speech, hoarse voice, and acute right-sided weakness. Physical exam shows weakness of the right arm and leg, and the left eye is depressed and abducted. It's down and out. So where's the lesion and what vessel is most likely involved? This is Weber syndrome. Left oculomotor nerve palsy, bulbar symptoms, and right hemiparesis. So this is a lesion of the left anterior midbrain, and the vessel involved is the left posterior cerebral artery. And that's it for now. I'll see you next time.